Hi everyone. Oh my gosh. So it has been a while since I've gone live. I apologize, but I'm sure you have been busy. You're busy, brilliant clinicians, and hopefully you've been enjoying your summer as well. So let's see. You know what? I think I'm gonna, oh my goodness, I want to try and go live on Instagram at the same time, but I'm not so tech savvy as you guys should know by now. Let's see. Okay, so let's see. Yeah, why not? Okay. So, if you're new to the group, we have a few new people. We always get new people, but especially when I'm running a new workshop, I always invite new people into the group. So, if you are new or if you just forget who the heck I am Melissa Biscardi. I'm a registered nurse, manual osteopath working in Toronto, and my clinical practice, my research focuses on concussion, and I'm just so passionate about the brain health, resiliency, and helping patients live their best lives and reclaim their lives. So today I just wanted to come on here, chat a little. My hair is just wild. What's going on here? I just wanted to come chat a little bit because, yes, the What the Neck workshop is happening this Sunday. A lot of you have already taken it. Some of you have taken it multiple times. It's always delivered a little bit differently. It's live Sunday. I'll, of course, post the link if you want to join. It's always such a blast. Now, of course, we know the neck is super, super important in concussion recovery. Why? Because the neck is basically always injured. There's always a component of whiplash when someone sustains a concussion, and that's just because the forces required for whiplash are much less than required to actually cause a concussion to happen. So we're going to focus on it for the workshop. And if you've ever taken a workshop of mine or one of the free master classes, or if you're in my big mentorship, you know that I focus on the facts. What do you need to know so that you can assess and implement strategies in your practice to help patients? I don't focus on the fluff. I've definitely been in courses, right, where you're just like, want to pull your hair out because things are dragged on much longer than they need to be. So, like I said, you're busy clinicians. You just need to know how to assess, how to put the pieces of the assessment together so that you can make decisions and so that you can have amazing results. So, yes, like I said, we're going to focus on the neck workshop with the neck. And I'm just going to take a couple minutes and chat a little bit about the SEM. So the sternocleidomastoid muscle, which I call the concussion muscle, right? When you sustain a concussion, the head is shaken in acceleration, deceleration. There are linear forces, there are rotational forces, and all of those forces involve the SEM. So it's fairly superficial muscle. You can literally grab a hold of your SCM. And if you saw my previous story on Instagram, I was saying my amazing colleague Chelsea, who's in San Diego, she thought of a great name for grabbing that SCM, and she called it the Vulcan grip. So I'm definitely adopting that, but giving her credit. So you can even just do that to yourself. Feel where the heck that SCM is. Now, the SCM, like I said, is definitely impacted in concussion, whiplash, a lot of other issues, and issues with it can be a driver of so many symptoms, and that is because of the attachments of the muscle, the nerve supply of the muscle, other nerves that pass through behind the muscle, of course, the blood supply, the lymphatics, which are underneath. So it's a super highway under there where that SEM is. So treating it, making sure the tissue itself is healthy and removing any restrictions in and around it is super important. So, you know, you're an amazing clinician, you know the neurology, but let's just talk about it. So, of course, the SCM is innervated by the accessory nerve, which is a cranial nerve. But there are also cutaneous, that word is always a tongue twister, but cutaneous branches from the cervical plexus. And those are involved in the sensory information, and actually those nerves, they have to do with the proprioceptive portion of the SCM. So yes, the SCM flexes, it rotates to the same side, but it's also gathering proprioceptive or position sense information. And okay, why is that important? Well, first of all, we need to know where our head is relative to our neck and the rest of our body. But when there is a disruption in this information, when we're getting miscommunication or errors, then that can lead to sensations of what? Dizziness or disequilibrium. So there is a component of the SCM that's involved in those sensations, in addition to, of course, neck pain. What else did I want to riff about? So the SCM is also connected to the greater auricular nerve. So that nerve that is involved in sensory information of the tissue basically around the ear. So why is this important? When we're thinking about sensory information comes in, it might be, like I said, mismatched, miscommunication, right? The quality of the information influences quality of output or sensation. So if that SCM is a mess, along with the rest of the neck, if there's impairment in blood flow, lymphatics, compression over the nerves, you're going to get, potentially sensations that are not desirable, or even contributing to things like tinnitus. So I've been talking about tinnitus a lot. I've been getting so many DMs from patients because this is unresolved. I'm sure clinicians do a great job of treating it, but not all clinicians. And so there are patients that need you to take the What the Neck workshop. So we're going to do a lot related to tinnitus, whether it's tissue tensions that are contributing to it, or also we're going to talk about tonotopic maps. I did talk about assessing and treating tonotopic maps in the neurology workshop, but we're going to cover it again because 1, I love it. 2, not everyone took the neurology workshop. 3, patients need it. So again, that's for tinnitus that's related to the tissue or the tonotopic map. If it's from medication toxicity, vitamin issues, trauma to the actual apparatus or tumor, etc., then manual therapy is not going to help. Now, what else? So I think that's it. I just wanted to chat about that SCM. Of course, I'm going to talk about so much more, but I'm just loving this SCM muscle these days, and my new language around the treatment of it with a short lever, which is using the Vulcan grip. So you can go ahead and massage your own SCM. Super, super nice. If you guys have been around, I used to call this neck milking, which always seemed a little bit weird. So just massage your SCM, see how nice it feels, improve that blood flow. You might feel one side is more tender than the other. So that's telling you something, right? Now, if you're a clinician, the link for the workshop's in my bio. I'm actually, if you're not part of the Facebook group, it's Concussion Rehab Lab, and I try and go live in there as often as I can, and just share what I know and encourage others to ask questions and share any interesting things that are coming their way. So this was fun. I know I talked at about a mile a minute. One interesting thing is that I listen to podcasts, as I'm sure many of you do the same, at a speed of 1.5. So I feel like then I end up talking at a speed of 1.5. But you're busy, so better for me to talk quickly and just jam back your ears with information as quickly and efficiently as possible. So I think that's all for today. I'm going to take some deep breaths. slow down a little bit. And I hope you have an amazing, amazing rest of the week. Either catch you in Facebook, on here, on Instagram, or in the workshop. And let's just keep helping patients recover and get their lives back.